Working hard on neuroanesthesia, we are moving on cerebral ischemia. The human brain is a highly metabolically active organ, accounting for about 25% of a person's metabolic demand, despite of comprising only 2.5% of a typical individual's body weight. Consequently, the brain is exquisitely sensitive to disruptions in blood flow. Complex homeostatic mechanisms act to maintain cerebral blood flow at a relatively stable rate of about 50 milliliter per 100 gram of tissue of brain, of course, per minute, through a process known as cerebrovascular autoregulation, which is very important. When this blood flow is compromised, the result is cerebral ischemia. One of the most common mechanisms of brain dysfunction and damage. What is the etiology of the cerebral ischemia? Cerebral ischemia can be of two types, like global and focal. Global cerebral ischemia is a result of systemic processes, often shock. The most common cause of global brain ischemia is systemic hypotension. Transient cerebral hypoperfusion can occur when autonomic and neurohormonal mechanisms that control blood pressure and heart rate are disrupted, as in vasovagal syncope and postural tachycardia syndromes. Structural and functional heart problems, mostly arrhythmias, are the second most frequent cause of transient global brain ischemia. When the effect is transient, manifests as syncope or a presyncope. Prolonged global ischemia, on the other hand, can result in permanent neurological damage or injury. In contrast, focal brain ischemia most commonly arises from obstruction of arteries or arterial blood flow to the brain, often as a result of thrombosis or embolism. If the ischemia persists long enough, irreversible neuronal loss occurs, resulting in an ischemic stroke. Sudden thrombosis of a previously stenotic cerebral or internal carotid artery, ruptured plaque, will lead to ischemia in a region supplied by the artery affected, of course. Embolization of a clot formed in the heart or a large artery is the most common source of brain ischemia. Emboli of other materials such as fat, air from an iatrogenic cause, or amniotic fluid during pregnancy, during delivery especially, are possible but much less frequent. Vasospasm is a relatively uncommon secondary cause of brain ischemia. This can be provoked by medication especially, or it can be secondary to trauma, inflammation, or recent subarachnoid hemorrhage. Notable that an increased incidence of stroke, ischemic stroke, has occurred with COVID-19 infection, viral infection. So, ischemic stroke etiology divides into the categories of large artery disease, usually secondary to atherosclerosis, occlusive, cardioembolic, like cardiac causes like atrial fibrillation, valvular abnormalities, or cardiac wall motion abnormalities after myocardial infarction, like small vessel occlusive disease affects small perforating arteries, often secondary to underlying hypertension. A stroke of other etiology like vasculitis or drug-induced, stroke of unknown etiology or cryptogenic stroke that there is no cause found after medical workup. And the next slide is about pathophysiology. Brain ischemia is, in its broad sense, can be focal or multifocal, caused by a sudden closure or marked diameter reduction of the artery supplying an area of the brain. Brain ischemia can frequently be triggered through the lack of global brain blood supply. In more proximal causes of hemodynamic dysfunction causing sudden blood pressure fail or a decrease in blood pressure. Ischemic brain tissue suffers necrosis in as soon as 5 minutes after a complete lack of oxygen and glucose supply, compared to 20 to 40 minutes in other parts of the body. Some areas are particularly susceptible to ischemia, a phenomenon known as selective vulnerability. These areas include the arterial border zones, pyramidal cells in the hippocampal areas, and cerebellar Purkinje cells. Arterial border zones are also known as watershed areas. The persistent complications of brain ischemia are due to permanent brain damage and are a final common pathway to necrosis. Neuronal shrinkage and death, gliosis and astrocytosis, a loss of volume of the whole brain. The brain has a high basal metabolic rate, and high cell signaling activates pathways such as glutamate-induced neuronal death, dopamine-induced potentiation of ischemic injury, free radicals formation and release, zinc toxicity, and release of enzymes leading to combination apoptosis and catabolic necrosis. In global injury, histologic changes become apparent within 12 to 24 hours of injury. The first changes seen are shrinking or swelling of neurons. After that, red neurons may develop as a consequence of cytoplasmic eosinophilia, nuclear pycnosis, and other necrotic changes. While most parts of the body affected by ischemia undergo coagulative necrosis, the brain is unique in that it undergoes liquefactive necrosis. This appears as viscous material containing numerous inflammatory cells such as neutrophils and cell debris under microscope. One of the important parts of the evaluation of any patient with neurological symptoms is a history of the presenting complaint. Cerebral ischemia results in negative symptoms related to loss of function of the cerebral or of the ischemic tissue. Cerebral ischemic tissue. Global cerebral ischemia typically presents as an alteration in consciousness. Transient alteration in consciousness, such as syncope or presyncope, may be precipitated by maneuvers such as standing, which may result in a drop in cerebral perfusion pressure, but initially in blood pressure. Severe or persistent global cerebral ischemia may result in a patient who presents with a coma. The symptoms of focal cerebral ischemia will depend upon the specific portions of the brain which are ischemic. Determining the time of symptoms or of symptom onset is ideal, but this may not be possible in most of the cases. In cases where the precise onset cannot be determined, clinical decision-making is determined by the less known time that the patient was normal. Asking from relatives or patient if it is in a conscious state. For example, lesions in the cerebral hemispheres may result in contralateral weakness and sensory loss. Signs of cortical dysfunction raise the concern for a large artery obstruction, such as a middle cerebral artery occlusion. Cortical dysfunction in the dominant hemisphere, typically the left, often results in aphasia, and a lot of different dysfunction depending on the zone that is affected by ischemia. So here we have a mnemonic for be fast, so memorizing fast what to ask and symptoms. For example, B for balance or loss of balance, eyes, change in vision, F is facial drops, arms, asymmetry in upper extremity strength, speech, difficulty with speech or slurring, time to alert the public that expediting time to a hospital is essential. In addition, medical history should be obtained in the presence of vascular risk factors such as hypertension, diabetes mellitus, atrial fibrillation, hyperlipidemia, tobacco abuse should be ascertained, as this information could provide clues as to a stroke etiology. All of them are risk factors and most common cause of producing ischemic changes. The initial workup of symptoms suggests of cerebral ischemia and should include basic laboratory assessments like blood glucose, complete blood count, chemistry, coagulation factors, EKG, and cardiac enzymes. If suspected myocardial infarction, especially. A stat non-contrast head CT should be obtained to rule out a hemorrhagic or mass lesions firstly. Vascular imaging such as CT angiogram or MRI angiogram can be very valuable in the acute setting. MRI or CT perfusion may be valuable in order to determine the viability of the ischemic tissue, because the fate of ischemic neuronal tissue depends upon both the extent and the duration of ischemia. Patients presenting with acute focal cerebral ischemia often have a regional or infarcted brain tissue surrounded by a large area of the ischemic brain, which may still be viable. This potentially viable region is known as penumbra. There has been extensive research in the last decade regarding neuroimaging modalities for determining the volume of ischemic penumbra. And as you see, symptoms that can assess any of the doctor, especially neurologists, like weakness in arm or leg or entire side of the body, one side or both, hemi or tetra, dizziness, vertigo, double vision, difficulty with speaking if a left side is affected, loss of coordination. And the last line is treatment for brain ischemia. The management of global brain ischemia is generally targeted at correcting the underlying cause. Supportive care should be undertaken to ensure adequate cerebral blood flow. In the case of acute ischemic stroke, the first priority is determining whether the patient is a candidate for acute reperfusion therapy or not. Intravenous thrombolytics have been in use for the treatment of acute ischemic stroke. Tissue plasminogen activator or TPA is currently the only thrombolytic agent approved by FDA or Food and Drug Administration for the management of acute ischemic stroke. Can be administered within 3 hours of symptom onset. However, studies indicate that it may be safe and effective if given as much as 4.5 hours after the development of symptoms. And here I want to mention once again that knowing the onset of symptoms is important. If it is known, it's okay. If not, thrombolytic therapy becomes dangerous for patients. For patients with acute ischemic stroke due to occlusion of a large vessel mechanical thrombectomy may be indicated. As discussed above, determining whether a patient is a candidate for thrombectomy relies on the time of symptoms, one said. Patients with suspected large vessel occlusion should be transferred to a comprehensive stroke center or thrombectomy-capable center as soon as feasible. However, the decision to transfer the patient should not delay or preclude treatment with thrombolytics if the patient also meets the criteria for TPA or tissue plasminogen activator. Outside of the acute period, the treatment of ischemic stroke is focused on secondary prevention and promoting recovery. So, it is necessary to evaluate stroke risk factors like diabetes, hypertension, tobacco use, hyperlipidemia, atrial fibrillation, and so ahead. Management of risk factors should be optimized in order to minimize the risk of recurrent stroke. For most stroke survivors, antiplatelet agents such as aspirin or clopidogrel are indicated for secondary stroke prevention. In some stroke subtypes, a short course of dual antiplatelet therapy with aspirin as well as clopidogrel may decrease the risk of yearly recurrence. In addition, high-intensity statins, rosuvastatin, simvastatin, or any of them has been shown to be beneficial. For stroke related to atrial fibrillation, anticoagulation is indicated. Factor Xa inhibitors are preferred over warfarin, but warfarin is taking orally and is more reasonable for patients. Patients with symptomatic carotid stenosis, for example, hemodynamically significant stenosis of the carotid artery to a stroke or transient ischemic attack, should be evaluated for carotid endarterectomy or a stenting, which is practiced nowadays. For all stroke survivors, smoking cessation, maintenance of ideal body weight, and regular exercise should be encouraged. That's all. Thank you very much for your attention. Hope this video is useful for you for understanding cerebral ischemia. This information is taken from NCBI article. I'll attach below the link and you can access directly and read by yourself. If you like this, you can leave many comments and make a subscribe. Have a great time, guys.